Good afternoon, sir. Good afternoon, sir.
Yes, good afternoon.
So we are about 8 students here.
Okay, so we can go ahead, no problem. Okay, share the slide.
Okay, sir.
Okay, we're going to look at endometriosis and adenomyosis. So, definition: endometriosis is the presence of endometrial tissue outside the uterine lining. Outside the uterine lining, which means even if the endometrial tissue is found within the uterus, but it is outside or beyond the endometrial inner lining of the uterus, means it is a form of endometriosis. And therefore, if they say you should mention sites of endometriosis, adenomyosis is also a form of endometriosis because the endometrial tissue is found within the uterine muscle. It is found only in women of reproductive age because it is women of reproductive age that cyclically undergo proliferation and shedding of the endometrium. Has a wide range of clinical manifestation, and the size of the lesion does not correlate with the symptoms, which means a woman may have few endometriotic deposits or will have more pain compared to a woman who has significant visible deposits in terms of the symptoms. Next slide. The pathogenesis of endometriosis is unknown, and just like preeclampsia, it is a disease of theories. Some of the theories include retrograde menstruation, altered immunity, genetic predisposition, amongst others. Next slide. Now, why is retrograde menstruation thought to be a risk factor for endometriosis? Now, this is because endometriosis has been found, the incidence or the risk is higher in women with frequent menses. In addition, the risk of endometriosis is higher in women with any obstruction of the genital tract, such as women who had imperfect hymen, transverse vaginal septum. They are thought to have an increased risk, and the risk is due to accumulation of the menstruum and its reflux through the tubes into the pelvic cavity, and also because viable endometrial tissue is still found within the menstrual blood, which means the endometrial tissue in the menstrual blood is still viable enough to implant and grow in other sites. Next slide. Next. So how does altered immunity predispose to endometriosis? Now, it has been found that women with endometriosis are associated with reduced activity of natural killer cells, which are cytotoxic T cells. They also have reduced or deficient cellular immunity, and women with endometriosis have been found to have a higher incidence of autoimmune inflammatory disorders. Most of these autoimmune disorders are due to abnormal immune function, and therefore women with endometriosis have been found to have higher incidence of autoimmune disorders. This suggests that immunity is one of the risk factors for endometriosis. Next slide. Genetic influence. There's a 7 to 9% increased risk of endometriosis among first-degree relatives or first-degree female relatives of patients. So if you have a patient who has endometriosis, there's a 7 to 9% higher risk of finding endometriosis in any of our first-degree relation compared to somebody who is not related to anyone with endometriosis. And this is said to involve the human leukocyte antigen B7 allele. Next slide. Now, what is the epidemiology of endometriosis? What's the prevalence? The prevalence of endometriosis is unknown, especially in our environment. However, it is said that 3 to 10% of women of reproductive age are affected by endometriosis. And endometriosis is found in around 25 to 35% of women who have infertility. So the incidence of endometriosis is higher amongst women with infertility. And it has been found that endometriosis is seen in 16 to 31% of diagnostic gynae laparoscopies. And that means the incidence is the prevalence is quite high. Next slide. But how does it present? How does it appear grossly? Grossly, endometriotic deposits may appear as red petechial lesions that are found on the peritoneal surfaces, from the pelvis, in the patch of Douglas, and the bowel. They may also appear cystic, dark brown or dark blue appearance, especially this is for endometrial cysts, endometriotic cysts in the ovary, known as endometrioma. They may appear as cysts, dark brown or dark blue or black cysts. And they also be only found, you may only find sometimes thickened peritoneal surfaces. Areas with thickened peritoneum appearing as if it's a scar on the peritoneum. And of course, the ovarian endometrioma, which is a common presentation. Next slide. So what are the risk factors, clinical risk factors? Now, family history. We said lesions of a woman with endometriosis have a 7-9% increased risk compared to those who don't have a family relation. It also found that women with early menarche, early onset of early menarche, menorrhagia, short menstrual cycle, prolonged menstrual flow. You see, if you notice, any risk factors clinical risk factors for endometriosis are related to the menses. Early onset of menses, short menstrual cycle, prolonged menstrual flow, heavy menstrual flow are all associated with risk for endometriosis. Similarly, low fertility, delayed childbearing, which means commencing childbearing at a younger age is more protective than delayed childbearing. In addition, women with congenital defects of the uterus and tubes are known to be associated with the risk of endometriosis, such as those with transvaginal septum, absent cervical aplasia. They are all at risk of endometriosis. Next slide. How do you classify endometriosis? There are several classification systems. However, what is the benefit or the usefulness of the classification system? Some of these classification systems involve a scoring of the severity of the disease. And such scoring systems are useful for reporting operating findings and for comparing different treatment regimens in different hospitals and different parts of the world. Next slide. So, how do you stage? This is the ASRM staging, the American Society of Reproductive Medicine staging of endometriosis. Stage 1, it has stage 1 to 4. Stage 1 is minimal disease, in which there's minimal growth, superficial lesions that are few found on the peritoneal surfaces. That's stage 1, minimal disease. Stage 2 is mild disease, where you have superficial lesions associated with deep lesions in the patch of Douglas, that's a cul-de-sac, with no ovarian endometrioma, which means no ovarian endometriotic cyst. Stage 1 is minimal disease, only superficial peritoneal deposits. And there are a few. That's the minimal, step 1. Stage 2 is mild disease. They have deep lesions in the patch of Douglas, but no ovarian endometrioma. Stage 3 is moderate disease. There are larger adhesions and one or two ovarian endometrioma. While stage 4 is severe disease in which there are extensive adhesions. Sometimes you only identify a frozen pelvis, so much adhesion that you will not be able to separately isolate ovarian endometrioma. And even when they are present, the ovarian endometriomas are larger. Next slide. What are the clinical features? Now, the diagnosis of endometriosis requires a high index of suspicion. Because if there's no suspicion of endometriosis, your woman may be coming to hospital with her complaints for more than 10 years before the diagnosis will be made. It is a disease of women of reproductive age, and the classical symptoms are dysmenorrhea, dyspareunia, infertility, with or without menorrhagia. Dysmenorrhea, dyspareunia, with infertility. Dysmenorrhea, dyspareunia, with infertility, with or without history of menorrhagia. Next slide. Now, it may also present unusually, which means the patient may not even have your dysmenorrhea, dyspareunia, or infertility. She may have one or two of the classical symptoms, but she may just come with unusual symptoms, and this include may just come with a nodule around the urethra, in the vagina, on the vulva, that bleeds cyclically. Sometimes she only present to you with a nodule around the umbilicus that bleeds cyclically during menses. They may also come with catamenial pneumothorax or catamenial seizures. And of course, they may also present, those with severe disease may also present with features of ureteric obstruction or bowel obstruction because of severe adhesions. Next slide. How do you, when you have a patient with suspected endometriosis, how do you examine them? Of course, you want to do a general physical examination like all patients. And of course, specifically, abdominal and pelvic examination are the key pointers to the potential or possibility of endometriosis, particularly the pelvic examination, where you might find cervical excitation tenderness with a tender posterior fornix. You may even find that the uterus is fixed and retroverted because of the adhesions from the patch of Douglas that are tying the uterus, holding the uterus posteriorly, so the uterus will be retroverted and fixed. You may also find adnexal masses due to the ovarian endometriomas, especially if they are very large. On the other side, you have to remember, you may also have a woman with endometriosis with normal physical examination findings, including pelvic exams. Next slide. Now, definitive diagnosis is achieved at laparoscopy or laparotomy. The reason is that at laparoscopy, you'll be able to identify the tissues clearly. Sometimes they're often found at laparotomy, where suspected lesions will be biopsied and sent for histology. So what are the differential diagnoses? Differential diagnoses include pelvic inflammatory disease, all pelvic tumors. It can also include pelvic adhesion due to other morbidity, such as previous pelvic abscess, previous rupture appendix. It will also present cause adhesions that may manifest like endometriosis. Next slide. So how do you prevent? Well, there's no specific prevention modality. However, if you suspect endometriosis, you only manage the symptoms. Next slide. Treatment is dictated by the patient's desire for fertility, her symptoms, her age, and her stage of the disease. Even though, remember, we said the stage of the disease does not correlate with the symptoms. And that's why what determines or determinants of treatment include first, her symptoms. Second, her age and desire for fertility. Then her stage of the disease. Next slide. So what are the modalities of treatment? Now, for women in whom you only find endometriotic deposits, let's say diagnostic laparoscopy for tubal patency assessment, and she has no symptoms. In such women, the management is just expectant. There's nothing. Probably the main reason for coming to hospital is the infertility. If you manage the infertility and she conceives, fine and good. Similarly, and then that's why for all patients that are asymptomatic, there's no specific treatment. Now, what about those who are symptomatic? The focus of this treatment is to alleviate their suffering, provide pain relief, analgesia, and this includes the use of non-steroidal anti-inflammatory drugs, especially for those with mild to moderate symptoms, especially pain, and it's usually useful for those who are of younger age, who are single, and who do not desire immediate fertility. Next is the provision use of hormonal therapy. Hormonal therapy, such as combined oral contraceptive pills, given to women for 6 to 12 months, decreases the symptoms of dysmenorrhea and may also retard or reduce the progression of the disease. Remember, combined pills is also only a short-term treatment because it depends on whether the woman wants to conceive or not. Next slide. You can also use progestogens. How do they work? Progestogens cause decidualization of the abdominal endometrium and eventual atrophy, and therefore they provide relief of the symptoms, particularly pain. And the types of progestogens used include medroxyprogesterone acetate, norethistral enanthate, that's Depo-Provera, Noristerat, and you can also use levonorgestrel containing IUCD, particularly if you are dealing with adenomyosis. All right? You can also use 19 norethistral derivatives, such as danazol, as it inhibits gonadotrophin release and also inhibits the mid-cycle surge of gonadotrophins. However, you must remember that danazol is associated with irreversible virilization effects, particularly the change in voice. You give a woman danazol, after a while, her voice changes to that effect, to sound like that of the voice of a man. And that voice change is permanent. It's not reversible. So that's why it is nowadays, danazol is the last resort. Usually there are alternatives that are better than it. Then of course you can also use gonadotrophin releasing hormone agonists, such as leprola acetate, Zoladex, that's goserelin, naferelin. There are very different types of agonists and antagonists. They are very good for treatment of endometriosis or even pelvic pain from endometriosis or even fibroid. However, they are usually given only for a short period of time, because when you use them for more than 6 months, they cause pseudomenopause and the woman will start presenting with menopausal symptoms, hot flushing, all those nasty symptoms. Because of that, the duration of use of gonadotrophin releasing hormone agonist is short, and if you're going to use it for more than 6 months, you have to provide what is called add-back hormonal therapy to supplement. You have to give her supplement for the estrogen and progesterone that your body is not producing. Next slide. What about surgery? Yes, there's a place for surgery in the treatment of endometriosis. However, it is usually either conservative or radical surgery. When you have endometriotic deposits that are identifiable, such as when you have endometriotic deposits in the rectovaginal septum that's associated with cyclical dyschezia, cyclical hematuria, severe dyspareunia. You can do a joint surgery with a general surgeon, and then you do a helictis and remove that nodule. Sometimes it may even involve recession and osmosis of the bowel, and eventually then the patient may be fine. Or it may also involve excision of the perisacral, doing perisacral neurectomy for intractable pelvic pain. It may also include laparoscopic intrasacral nerve ablation, even though people are arguing whether it is effective or not. That's lunar. You can also end up doing radical surgery. If the woman does not wish to deliver again, does not want to continue her fertility, you can do total abdominal hysterectomy and bilateral cervical oophorectomy and remove the entire endometrial source of the endometrial tissue. Another treatment, of course, is also assisted reproduction. For women who have infertility and want to conceive, and in whom conservative routine methods, medical treatment of the infertility has no yielded result. So you can end up, or she's old, or there are multifactorial infertility, you offer assisted reproductive technology such as IVF and embryo transfer, or sometimes even you start from ovulation induction, IUI, or IVF. Next slide. So what is adenomyosis? Now, you should know that in some books, you may notice this as they will not put adenomyosis, but they'll write in endometriosis interna or endometriosis externa. The endometriosis that is located in the pelvic cavity, pelvic abdominal cavity, outside the uterus is known as endometriosis externa. But the one that is deposited that is within the uterus is known as endometriosis interna. This is the one, adenomyosis, because it is the presence of endometrial tissue in the myometrium of the uterus. And this endometrial tissue may be found as a focal, as a solitary focus, that's a distinctive nodule, or it may be diffused within the muscle. And the diffuse one tends to cause more symptoms and is difficult to treat, while the distinctive nodule is easier enucleated and treated effectively. It is found that in about 20 to 60% of uteri examined at histology, 20 to 60% of all uterus examined at histology contain identifiable endometrial tissue within the muscle layer, which means virtually all women have some form of adenomyosis or the other, depending on the extent and the age. Next slide. It is common among women with a history of childbirth. So now, while endometriosis externa is found in 25 to 30% of women with infertility, endometriosis interna, that's adenomyosis, is commonly found among women who have given birth. The exact cause of adenomyosis is not known, but the theories include: 1, postpartum endometritis, metaplasia, and the reason suggesting is that during after delivery, the whole uterus is soft, and again the force of contraction, retraction during labor may cause the muscle layer to give in some places, and the endometrial tissue may seep in. And then, because we said even in the menses, the viable endometrial cells are present. So once the endometrial cells go into the muscle layer, they'll keep on proliferating. While the metaplastic theory says that it is just that within the muscle layer of the uterus, there are inherent multipotential stem cells that also, rather, that some of the muscle cells undergo metaplasia to change from muscle to glandular cells, and therefore they form endometriotic glands. Next slide. As you said that also prolactin and FSH also contribute to that. Now, how does the uterus with adenomyosis appear? Usually the uterus with adenomyosis is usually uniformly enlarged. It's not like fibroids where you see the uterus totally disfigured because of fibroid nodules growing in different parts. In adenomyosis, the uterus is usually uniform, globally enlarged. And the fundus of the uterus is the most affected part. And when there's adenomyosis, the endometrial myometrial junction is not clearly identifiable. All right. And again, adenomyosis may coexist with uterine fibroid. We've seen many. You are doing myomectomy, you touch one place, things is a fibroid, you cut, nothing. So you only identify the change of color of the tissue and it looks different and feels stomach, so you excise it out. Next slide. Now, 70% of women with adenomyosis are symptomatic, and it's usually common amongst women aged 40 to 50 years. Luckily enough, symptoms of adenomyosis tend to decrease or regress after menopause because endometrial tissue are estrogen dependent, estrogen responsive, estrogen sensitive. Once the circulating estrogen level is reduced following menopause, they will gradually regress and symptoms are relieved. Next slide. What are the clinical features of adenomyosis? Dysmenorrhea, menorrhagia. Dysmenorrhea, menorrhagia. The other one, dysmenorrhea, dyspareunia, infertility. This one, dysmenorrhea, menorrhagia. All right. What are the main findings of examination? You found a globally enlarged uterus. The uterus is bulky, but it is globular and smooth. So what investigation will clearly help you identify or diagnose an adenomyosis? One, ultrasound scan, especially a high resolution, high definition ultrasound scan will clearly help you identify this lack of clear distinction between the endometrium and the myometrium where there's an adenomyosis. And then the best imaging technique to diagnose adenomyosis is magnetic resonance imaging to show you clearly distinction. Next slide. What are differential diagnoses? Of course, differential diagnoses include pregnancy, 2, submucous fibroid, 3, intramural fibroid, 4, pelvic congestion syndrome, 5, pelvic endometriosis. Yes, based on symptoms, it may mimic pelvic endometriosis, pelvic congestion. Based on an appearance of the globular enlargement of the uterus, it may mimic pregnancy. But of course, how do you differentiate it? No amenorrhea, pregnancy test negative. Fibroid can manifest the same symptom, menorrhagia and dysmenorrhea. Fibroid can also present the same way. Next slide. What are complications? Complications include menorrhagia and its attendant consequences, anemia, requirement for blood transfusion. Another complication is endolymphatic stromal myelitis. Next slide. What's the treatment? Treatment can be medical or surgical. The medical treatment include the use of hormonal agents, such as combined oral contraceptive pills. You can use progestogens. All other progestogens mentioned in the treatment of endometriosis can be used. Likewise, the combined pills. But remember, whenever you're using a hormone, the patient must meet the medical eligibility criteria before you use them. Then, of course, other medical treatment include the gonadotrophin-releasing hormone agonists, such as leprolide, goserelin, nafaradine, and even newer antagonists are available in the market. Surgical treatment is also available, and this could include either, if the adenomyosis is focal, you just remove the nodule, which is called this adenomyomectomy. You remove the adenoma nodule and reconstruct the uterus. In some situations, you may just have to do total abdominal hysterectomy. The woman has completed her family size and does not wish to retain her uterus. Next slide. Next slide, please. So, prevention, there's no known preventive modality. But if you notice, while endometriosis can relatively be prevented by early onset of childbearing, adenomyosis could result later on because childbearing is the biggest risk factor for adenomyosis. Next slide. Okay, so if there's any question, you can ask. We'll go to the next topic, the last topic for today.
Sir, I have a question.
Okay, Alima. Go ahead.
But it's not related to this class.
No problem.
Sir, please, you said?
Go ahead.
Okay. So how does dexamethasone affect fertility or causes infertility?
Dexamethasone causing infertility.
Steroid.
Now, generally, steroids are not drugs to be taken lightly, because whenever you take exogenous steroids for a longer period, what they do, they cause a negative feedback on the pituitary, and you create a sort of artificial adrenal crisis. Remember, the dexamethasone is which form of steroid? Is it predominantly mineralocorticoid or glucocorticoid? I think it is a glucocorticoid. So it decreases. Yeah, it eventually decreases your level of cortisol, and by extension, usually at the level of the pituitary, there's something that happens. If any of the hormones is being excreted in large quantity, the others are reduced. Now, that's the same reason why if you have hyperprolactinemia, you have relative gonadotrophin deficiency, and the woman will have amenorrhea, and the woman will have infertility. At the same time, when somebody is taking steroids, the level of cortisol decreases, and the pituitary increases the amount of cortisol, adrenocorticotropic hormone. Higher adrenocorticotropic hormone will result in reduced synthesis and release of gonadotrophins, and therefore there will be relative, either there will be amenorrhea, oligomenorrhea, and then there will be infertility. It's the same thing. It's just the way higher prolactin level causes amenorrhea and infertility. The same thing, higher ACTH will now eventually lead to low gonadotrophins and infertility. But you also remember again, exogenous steroids will also produce what? Cushingoid features, right? Artificial Cushing syndrome. Next slide. Next question, Karada. I think you said you had a question yesterday.
Oh, yesterday. Okay,
yeah.
Sir, the most common cause of vesicovaginal fistula in Nigeria.
The commonest cause?
Yes, sir.
Is obstructed labor now.
Okay. Obstructed labor.
It's vaginal delivery.
Obstructed labor.
VV Africa.
Okay.
Yeah.
Is it feasible after VV Africa?
What question is that?
Sorry, the question is that can vaginal delivery be attempted after vesicovaginal repair?
No. Yesterday when we talked about cesarean section, it was clearly mentioned among the contraindications. Guys, for your exams, The answer is no.
Yes.
If you are come for postgraduate, you can argue that one out. But for now, VVF repair, any previous VVF repair is a contraindication to vaginal delivery. You understand? Remember,
Okay,
yesterday
thank you
we
very
talked
much.
about indications for CS, right? Indication for CS. It was mentioned there. Previous VVF repair is an indication for cesarean section, right? It was on the slide. So
Okay, yes, sir.
once there's a VVF repair, it is a contraindication to vaginal delivery. So it's an indication for CS.
Okay, like even diabetes. I don't know.
Any question again? Before we proceed? There's a second present. There's a third presentation I think we didn't do. We're supposed to do 3 yesterday. Do 3 yesterday.
I think that is all, sir.
No,
The lectures are finished.
no. Where is what do you call him? Ben.
Dr. Ben.
Yeah,
Dr. Ben
we're
is
supposed
not
to.
around.
No. Let me check. Hold on. Let me just check. I have the
Okay, sir.
list of infertility,
I wasn't like this at all.
photographs, design section. There's a fibroid, lecture on fibroid.
Oh, yes. We haven't done fibroid.
Yeah, there's a lecture on fibroid.
UTI. No, we did UTI.
We're supposed to do fibroid and then we'll do UTI some other time. So what do we do now? Do we do fibroid and put a date for UTI? Because there should be a date that will do practical on pathograph.
Okay, sir.
Yeah, there should be a day we'll do practical on pathograph.
2, 3, 4, 5, 6, 7, 8.
Okay,
This
sir.
one, we are going.
19,000.
We are going to skip. We are going to skip over a lot of the slides because there are a lot of pictures on the slide. So, all right, next slide is a commonest pelvic tumor. Next slide. So, what are the causes of uterine fibroid? The exact etiology is not known. However, it is a tumor known to be associated with excessive exposure to estrogen, hyperestrogenic state. Go back. Okay. And of course, infertility. If the womb doesn't carry a baby, it will carry a fibroid, right? So most women with fibroids either have prolonged infertility, which means they've been exposed cyclically to increased levels of estrogen without respite, and that's where they end up presenting with uterine tumors. The fibroid is the commonest tumor. Next slide. Mechanical stress is just a grammar. So how does it appear at pathology? Now, the shape and size of the fibroids vary. Of course, but the consistency is usually unique. It is firm. It's usually capsulated, and there are several varieties. Next slide. And there are also different methods of classification, right? Next slide, please, Halima. Next slide. This is just a differentiation, difference between a benign fibroid and its malignant component. The malignant component, okay, now, what are the varieties of fibroid? It could be uterine, could be extrauterine, then it could be disseminated. Now, the fibroids within the uterine can be divided into two, corporeal and cervical. The corporeal fibroid is also divided into several different types. While extrauterine fibroid could be round ligament fibroid, broad ligament fibroid, rectovaginal septum fibroid, or fibroid in the uterosacral ligaments. These are mainly around the ligamentous tissues around the genital tract. Then the leiomyomatosis is when you have disseminated intra-abdominal fibroid ceilings distributed, usually found within the omentum, the broad ligament. Next slide. So, corporeal fibroid, that's fibroid within the uterine body, is the commonest, accounting for 95% of all uterine fibroids, while cervical fibroids account for 1 to 2% and are usually, luckily, they're usually solitary, while fibroids found on the uterine body are usually multiple. Next slide. Next slide. This is a submucous fibroid polyp. Now, the fibroid that is found in the uterine body is also subclassified into 1, intramural or interstitial. Intramural or interstitial is the same. Please don't confuse this. Intramural and interstitial mean the same thing. They account for 58%. You have subserous accounting for 18%, and submucous accounting for 24%. So uterus found in the uterine body, the commonest is what? Intramural or interstitial, followed by submucous. Next slide. Next slide. This is a hysterectomy specimen. Now, this is how they appear. This one is intraligamentary, found in the broad ligament. This one is pedunculated submucous. This one is pedunculated subserous. This one is intramural or interstitial. This one is subserous. This one is submucous. Next slide. This one is cervical. Now you should note, go back to the previous slide, please. Please note this picture, please. You may be given something like this, a picture, let's say the first picture up here, on a slide, as a picture at an OSCE station, with an arrow pointing to one of them, and I tell you to identify this. Please look at them very well. Intramural is located within the muscle fiber. Subserous is located beneath the serosa. Submucous is just touching the endometrial lining. And there are 2 types of submucous fibroid. There's one that is pedunculated submucous. It is hanging on a pedicle within the uterine cavity, right? And there's also a pedunculated subserous. It is hanging by a pedicle onto the uterine serosa. So you may be shown any of this on a drone and a diagram to identify what type of fibroid or what it is. You score higher when you say this is intramural fibroid than this is a fibroid. So please, those note the positions. Next slide. We just talked about adenomyosis. If you look at the fibroid nodules, they are distinct. What adenomyosis is just diffuse area of alteration in the myometrium. Next slide. For cervical fibroid, we say it accounts for 1 to 2%. You can have cervical fibroid can be located either within the portio vaginalis or in the supravaginal cervix. You know the cervix has 2 components. The one that has the part of the cervix that is jutted down into the vagina, which is called the portio vaginalis, and the supravaginal part, the part of the cervix that's above the vagina, which is known as the true cervix. You may find the fibroid in any of this. And it's usually more difficult because the one at the portio vaginalis is usually, especially if it's pedunculated, easily removed by avulsion without no extensive surgery. But the one in the supravaginal cervix, especially if it is lateral, can be associated with significant bleeding at surgery because of the descending vaginal branch of the uterine artery that is passing around or close to it. Next slide. Now, what is the consistency of the fibroid? A fibroid without degeneration is usually firm in consistency. However, if it has undergone generation, the consistency may change. It is harder in consistency if the fiber had undergone a hyaline degeneration. It becomes soft if there's cystic degeneration or in pregnancy, and becomes stony hard if there's calcific degeneration. Next slide. Next slide. So how is the appearance of the fibroid nodule when cut? The cut section of uterine fibroid nodule reveals well-demarcated surrounding muscle fibers that are wholly and comprising of interlacing, intermingling fibers and fibrous tissue, and it usually appears paler than the surrounding normal in the myometrium. Next slide. And that's what you use to differentiate when you are doing surgery. As soon as you're cutting, when you reach the fibroid nodule, the texture you feel as your knife goes in, and the color will change, and you tell you have reached the capsule of the fibroid so that you will be able to enucleate it. Next slide. This is the histologic appearance under the microscope. Interlacing bundle of fibers. Next slide. On microscopic examination, you have smooth muscle cells and fibrous tissue with few blood vessels. And that is why it appears paler than the surrounding normal myometrium, because there are few blood vessels and increased tissue hyperplasia and hypertrophy around. Next slide. This is how it appears on histology. Dense network of smooth muscle fibers with nuclei all over the place and fibers. Next slide. Don't worry, we'll show you this at MDCN exams. Next slide. Nobody will show you something with this. So, what are the changes that can occur with fibroid? There may be general changes. There may be changes within the genital tract as a result of the presence of a fibroid, and there may be changes within the fibroid itself. Next slide. General changes include erythrocytosis, increased red blood cell synthesis, polycythemia, carbohydrate hyperglycemia, and anemia. Now, anemia may result from repeated menorrhagia, right? While polycythemia may result because of huge fibroid that is compressing the ureter, and then resulting in hydronephrosis with pressure at the renal pelvis, leading to increased synthesis of erythropoietin and leading to increased erythropoiesis, and you have polycythemia. But this is rarer than anemia. Anemia is commoner than polycythemia in fibroids. Next slide. In the genital tract, the endometrial cavity myometrium as a whole may be distorted. There will be enlargement, there will be distortion, and there may also be salpingitis, inflammatory changes in the tube, as well as there may be some form of oophorytis. And also, at the same time, there may be associated ovarian endometriomas. And again, uterine fiber is found in association with endometriosis in 30 to 40% of cases. And of course, the endometriosis may be internal or external. which means this endometriosis being talked about here, 30 to 40%, maybe adenomyosis or pelvic endometriosis. Next slide. So within the tumor itself, what are the changes that could occur? One, it can undergo atrophy. This is common by the time a woman reaches menopause. It will undergo atrophy, and the symptom is producing, and everything will gradually regress. It may undergo degeneration. This degeneration can be hyaline degeneration, cystic degeneration, red degeneration, fatty degeneration, or cancerous or calcific degeneration, right? It may undergo necrosis. Remember, we said at the cut surface, you have interlacing bundle of muscle fibers and few blood vessels. Now, because of the few vessels, as the fibroid is growing faster, it will outstrip the blood supply, and sometimes it undergoes spontaneous necrosis. Rarely, it can undergo malignant transformation, particularly if there's rapid growth of the fibroid after menopause, because it is not expected that after menopause, a fibroid should grow. But if there's rapid growth of a fibroid after menopause, there should be a suspicion of malignant transformation. There may also be vascular changes. There may be edema because of the increased growth of the fibroid at the expense of the vascular supply. And because of that, there'll be blockage of the lymphatics, causing edema and eventually lymphangiectasia, which is obstruction of the lymphatic blood vessels. Rarely it can undergo infective transformation, maybe because if there's necrosis in the fibroid and there's any infectious source around, you can just get infected, and then you now present with fever, all features of systemic infection. But the infection can also be local, where there's some degeneration, especially if you have, let's say, a cervical fibroid that has grown big, and then maybe cervical fibroid polyp that has grown big. There's some ulceration of the polyp, and then you can get infected. Next slide. Now, what are the genetic changes? As the fibroid enlarge, their blood supply, they will outgrow their blood supply, and it will lead to various types of degeneration. There can be hyaline degeneration, in which there's presence of homogeneous bands of eosinophilic bands, or plaques of extracellular or plaques. Okay, what happens is that what differentiates this degeneration from the other is that when you stain, you have eosinophilic staining, which means the tissues stain better with eosinophilic stains. You can also have mixed degeneration, which there's gelatinous intratumoral foci at gross examination because it contains hyaluronic acid-rich mucopolysaccharides. So it means you have this mixed degeneration is the same thing as, what do you call it now? Okay, hyaline degeneration, mixed degeneration. What's the next one we said? Calcific, cystic. Yeah, this is something as cystic degeneration. Next slide, because gelatin is soft, so the fibroid will appear and feel soft. Next slide. Red degeneration. Red degeneration is said to occur during pregnancy, commonly during pregnancy, but it can occur even outside pregnancy. It is due to venous thrombosis within the periphery of the tumor, or due to rupture of intratumoral arteries. And that is why it is painful. It's associated with significant pain and fever. There can also be sarcomatous transformation, which occurs in between 1 to 3%, usually less than 3% of fibroids undergo malignant transformation. This malignant transformation in a fibroid can be written as malignant transformation or sarcomatous transformation, because sarcoma, it is the malignant tumor of the soft tissues, of the connective tissues, including muscle. That's why it can be written as sarcomatous transformation. So if you see sarcomatous transformation related to fibroid, it is true. That's talking about malignant transformation. Next slide. So what's the diagnosis? Diagnosis is achieved based on symptoms, findings on examination, and investigation. The major symptomatology is bleeding, menorrhagia or menometrorrhagia. Now, menorrhagia is characterized by menorrhagia, heavy menstrual flow, heavy and or prolonged menstrual flow that is cyclical. It's heavy and or prolonged menstrual flow that is cyclical. In some patients, there will be metrorrhagia, mid-cycle bleeding, intermenstrual bleeding. Particularly, it is particular when there's a significant submucous component of the fibroid. When there's a huge or significant submucous component, they can have intermenstrual bleeding, or known as metrorrhagia. There can also be pain, which can be uncomplicated. There may also be pain due to complications such as degeneration, malignant transformation, infection, or torsion. So the pain from a fibroid can result from the fibroid itself, such as dysmenorrhea or even dyspareunia. There can also be pain due to a complication. When you have a large subserous fibroid that is pedunculated, that's undergone torsion, it can cause significant pain. I think recently I had a patient like that. The pedunculated subserous fibroid was much bigger than the uterus itself, and the pedicule had twisted like 4 times. She was always in pain. And she had only one intramural fibroid, while that big one is almost like 20 by 25 centimeters in size. This pain can also be due to an infection, right? Then, of course, there may be the presence of a mass, tells she has heaviness in the lower abdomen. There may be associated pressure symptoms, dysuria, urinary frequency, constipation, dyschezia, because of the pressure of the huge mass in the pelvis. There may be infertility, and there may be abnormal vaginal. This is very common with pedunculated cervical fibroid. It will cause you having discharge. Next slide. And you start thinking of cervical cancer only for you to do VE, and you see one big fibroid nodule there. Signs. Whenever you examine a patient with a fibroid, when the uterus is symmetrically enlarged, what are your differential diagnoses? When you suspect fibroid and you examine the patient and you have symmetrically enlarged uterus, this one I will talk. What are the differentials? Differentials are one, submucous fibroid and adenomyosis. Remember we talked about adenomyosis before. When the uterus is enlarged, but it is symmetrical, it is either adenomyosis or a submucous fibroid. When you have asymmetrically enlarged uterus, usually when you have intramural and particularly multiple subserous fibroids. Next slide. What are the investigations? Of course, clinically, you take your history, you do laboratory tests and do imaging studies, and you may also use some instruments at the bedside to help you make a diagnosis. Next slide. The investigations you do, well, you may do MRI when you have it, but for us here, it's a waste of time. It's a waste of money. Most of our people come with fibroid that is obviously fibroid. From the history, from the examination, you don't need to resort to MRI. Next slide. Next slide. Whenever there are fibroids, that's how they appear, enhanced appearance of the image. Next slide. Next slide. Next slide. Next. Differential diagnosis. Adenomyosis. It is most commonly a diffuse abnormality when we occur as a focal mass, which means when you have an adenomyoma, adenomyosis, it is focal, it's adenomyoma. If you have adenomyosis, the uterus is also enlarged. But the difference is that, remember this one, and I said adenomyosis and fibroid can present the same way. Menorrhagia, dyspareunia. Dysmenorrhea, menorrhagia, they can present the same way. The only difference is that in most patients with uterine fibroids, the fibroids are multiple, especially in the environment. The fibroids are multiple. So they will have submucous, intramural, subserous. So you'll be able to differentiate when you examine the uterus. But for adenomyosis, if the fibroids are not many, the fibroid may just be the same, feel like the same with adenomyosis. And but the only good thing is that if you do MRI in this case, to clearly differentiate between the two for you. Now, next slide. Next slide. So this is a huge uterus due to adenomyosis, and this is how it appears. Another differential diagnosis is what? Adnexal mass, such as ovarian fibroma. Even when there's an ovarian mass, you can differentiate it on imaging. You can also differentiate it on examination, especially if there's no accompanying pelvic adhesions. When you do pelvic examination, you may be able to differentiate between the two. Next slide. Next. 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 Now, these tumors are benign, and their symptomatology is not the same with fibroid. Fibroma and brainal tumors they will not present with menorrhagia. They may present with dyspareunia, they may present with dysmenorrhea, but they will not present with menorrhagia. So you can use that as a differential. Another differential is what? Pregnancy. It's important to make sure that you rule out pregnancy. Next slide. Next slide. Next slide. Now, another differential is uterine leiomyosarcoma. This can be a situation whereby there's sarcomatous transformation of a pre-existing fibroid. A woman with fibroid that undergoes malignant transformation into a uterine leiomyosarcoma. Or from the beginning, it starts as a tumor, as a malignancy. So it can be de novo or secondary to a malignant transformation in uterine myoma. Now, the diagnosis is established at histology. And that's one of the reasons why all women who had myomectomy must have the fibroid nodule subjected to histology, so that if there's any malignant transformation, it will be detected early and the woman will be appropriately counseled. Next slide. Next slide. What's the treatment? A large number of patients with uterine fibroid are found incidentally. The woman has come for infertility evaluation. As part of the routine check, she's asked to do ultrasound, and they say she has some fibroid. They don't do anything. Virtually most women of reproductive age who are in their late 20s and their 30s and 40s, if they do ultrasound, there will be some form of fibroid or the other. So in most instances, treatment is not necessary. In some situations, they have a fibroid, but it's not symptomatic, and probably she's around menopause. She's at the perimenopausal age. So you can manage her conservatively and see what happens. Then another option is radiological, interventional radiology. In that case, the woman has a fibroid, especially if it's a solitary fibroid that is causing symptoms, and she's around the age of menopause, and she doesn't want hysterectomy. You can do uterine artery embolization, which is done by the interventional radiologist. They cannulate the femoral artery, pass their catheter up to the external iliac, pass it back into the common iliac, then pass it into the internal iliac, then go to the anterior trunk of the internal iliac, identify the uterine artery, which is the division, which is the branch of the anterior trunk of the internal iliac, then identify the uterine artery and inject fluorescence into the uterine artery, which will now obstruct the blood flow to the uterus, and therefore it will limit the blood supply to the fibroid. In fact, not only blood supply of blood and supply of estrogen to the uterine artery, which will now lead to shrinkage of the uterine artery. It can also be done surgically. You can do also another interventional approach, which is the magnetic resonance imaging guided focus ultrasound. In this case, you have a solitary fibroid and you have the facility. So this is basically more of experimental. They identify the ultrasound with MRI, and they now focus high frequency ultrasound waves to the fibroid, which will now lyse it. But this treatment is mainly experimental for now. It's not available in most parts of the world. Then, of course, you can use generate agonist or antagonist. In this case, the woman is 46 or 48. She's just perimenopausal. She has some fibroids, not many, and then she doesn't want to get pregnant. Or she has a contraindication to surgery. Maybe she has a bleeding diathesis, and maybe she's a known hemophiliac. So you want to avoid that surgery. So you can now give her gonadotrophin releasing hormone agonists for up to 6 months. They will cause pseudomenopause, block the supply of availability of estrogen, and the fibroid will shrink. And then when she goes, maybe as you induce your chemical menopause with your drugs, the natural menopause will come in, and that's all. Of course, surgery. Surgical management can be uterine sparing or radical. Uterine conserving surgeries for fibroids include polypectomy for removal of cervical fibroid polyp, myomectomy for removal of any other type of fibroid. The myomectomy can be done open, the way we do here, or laparoscopic, depending on the size and the number. And of course, the definitive treatment, surgical treatment of fibroid, is total abdominal hysterectomy. Hysterectomy. There will be no recurrence. Once you yank the uterus out, there will be no recurrence again. So the choice of treatment depends on the patient's symptoms, her age, parity, the number and size of the fibroids, and the type of fibroids, as well as complications, potential complications, or the existence of complications at that time you're seeing her. So this will determine if she's perimenopausal, she doesn't want even the uterus, she wants it out, you remove the uterus. She wants to retain her uterus, either for reproduction or just for her self-esteem, you do myomectomy. If she's not fit for surgery, you do either conservative medical, or you do radiology if it's available. Next slide. So we said myomectomy, of course, polypectomy, hysterectomy, we've talked about them. Let's go. Next slide. This one. Next slide. Next slide. This one I can't see. All right, so thank you very much. Any question, Halima? All right, if there's no question, we'll fix the date for our. Okay, Nuruddin.
Sir, if and for example, during cesarean section,
Okay.
and you come across the leiomyoma,
You do nothing. Let it be. Now there are exceptions. Now, in general, when myomectomy during section, what are the reasons for that? Pregnancy is associated with great cardiovascular changes, and these cardiovascular changes are necessary adaptations to accommodate for the increased demands of fetal growth and development. And these changes include increase in the size of the uterus with hyperplasia, hypertrophy of the uterine muscles, and increase in the blood supply to the uterus, such that at term, the uterus takes almost 1/4 of the cardiac output per minute, which means there's increased blood supply and therefore increased risk of significant hemorrhage when you do myomectomy, right? So because of that risk, myomectomy is not advocated for as cesarean section, except in a very rare situation. What are those kind of situations? For instance, you have a patient you've taken to theater for surgery for CS, and then you find out that she has a huge fibroid in the lower segment. Let's say even it's more of a serious fibroid in the lower segment. They cannot cut it through to remove the baby. In that case, if it's not too big, you can just remove it and take precaution. So that as soon as you remove it, you remove the baby and quickly achieve hemostasis. And you must make sure that you're sure you've achieved hemostasis before you close that woman. Because of the increased blood supply to the uterus, increased vascularity, the risk of hemorrhage is very serious. Most of you will not know, but Mofe Damijo, the wife of Richard Mofe Damijo, his first wife, died because she had myomectomy at cesarean section. She was a celebrity that died because she had cesarean section, myomectomy at cesarean section. It was done by, I think, Agbola, I think. The famous Agbola, the one who wrote that book. Because that Agbola was one of his compares that did the myomectomy at CS. So that's the reason why it's not advised. But you know, in life or at surgery, circumstance eventually dictate what the surgeon would do. But what is the key guide is what? His experience, his skill and experience will help him navigate that difficult situation. But in general, it is not advocated. Because if you routinely advocate for something, then a time will come when somebody with less experience and less skill will do it and you put the patient's life in danger. You understand?
yes, sir.
Okay, Nuruddin.
And sir, I have another question.
Okay.
Can smoking be a protective factor for uterine fibroids, sir?
Smoking is said to be protective against How's that disease safe in obstetrics? Is it preeclampsia or there's one disease that it protects, but it may not be protective really. It may not be. The reason is that smoking is associated with, it's said to be a risk factor for early onset of menopause, early menopause. And therefore it effectively reduces the estrogen levels. But it may not be, I'm not sure, not really sure. Because you see, whenever you say something is protective, it's as good as saying, no, that they do am to protect you from having disease. But have you ever come across where it is said to be protective?
Yes, sir. There is one book that I'm reading. They said there are protective factors for uterine fibroids: multiparity, smoking, and GnRH analog. And GnRH analogs.
Well, GnRH analog, they are used for treatment, and they are not really protective, but they are treatments. Because you know, if GnRH analog, say take it because I want to prevent you from having a uterine fibroid now. You understand? They are used as treatment. Cigarette smoking may be protective, but it's not really a good protection anyway. You are preventing one problem and getting the other. You understand?
Yes, sir. Thank you very much, sir.
Any other question, please? Halima, you don't have question today? So I think in the absence of any other question, I will discuss with Ben. We'll fix a date for the practicals and we'll have a lecture on UTI and recurring UTI, okay? For the exams.
Okay,
So all
sir.
the best.
Thank you very much,
All the
sir.
best. All right. Bye-bye.
All right, sir.